So the first question, Ramin, I'm going to ask it of you. What are typical head injury patterns in the elderly?
Not good. It's not good. The patterns aren't good. The question here, this was a group that was looking back at a study, the Nexus 2, which is a head injury decision tool designed to reduce CTs, and they specifically went back and looked at the elderly patients in that cohort. They basically did a chart review and found about 3,600 elderly patients, elderly as defined by 65 or older. I think many of our folks would still debate that they feel that they're elderly at 65 and older.
No.
But all these patients got a CT head, and then they went back and examined what the patterns were for those that ended up getting these CTs, how many injuries did they have, what were their mechanisms. I think there's a lot of useful information in here, actually. They found that out of those 3,600 elderly patients that did get a CT head, 14% had injuries, 10% of them were significant. 5% got neurosurgical procedures. And here's the kicker. You would think were these people that had significant bad mechanisms, 70% of the patients in this cohort were ground level falls. So what they didn't look at and what they didn't report on was anticoagulation use. But I think you could, extrapolate that out of 70%, there's no way that all of those were possibly anticoagulated. And there's a significant proportion of even the ground level falls that ended up having bleeds and significant bleeds on their head CT. So the bottom line here is elderly patients with falls have a very, very low threshold for CT. Limitation of this study is there's a reason these patients got scanned. So you're taking patients that had a pretest probability high enough that ended up getting the scan. So, but I think we have to be very, very judicious, and I think this tracks with all of our practice. Elderly patient, even in the setting of ground level fall CT, any patient anticoagulated, not part of this study. You're going to talk to us about?
I am going to talk about that. So there was an Italian study that was done, as we're going to abstract number 93. There's an Italian study done that showed there's an 8% risk of delayed intracranial hemorrhage in a selected sample. And so since that study was done, we've been trying to prove that that is not actually 8%. Do you guys remember when it came out, all of a sudden we were putting patients in observation because they might have a bleed, because the 8% is higher than the 2% all-cause mortality for going into the hospital, right? And so we were putting patients into the hospital. Multiple studies have come out wanting to see if that was actually true. Can we reproduce these numbers? And they've been okay. This study, though, is a prospective study, and it was done at 2 level 1 trauma centers, and it was done in Florida. They excluded patients that were on antiplatelets. So the only patients that were included in here were patients that were not on anticoagulation. They were on one of the DOACs, or the direct the newer, I call them NOACs, but like dabigatran, rivaroxaban, apixaban, Pradaxa, Xarelto, Eliquis, those 3 medications, they were on that, or they could be on one of the heparins, so heparin or Lovenox. And the majority of the people that were actually included in this did not have any anticoagulation. So about 67%, or 2,300 people, were not on anticoagulation, and then the remaining 32% were combined and on one of those forms of anticoagulation that we discussed. And they wanted to see when they had blunt head trauma, an average, they had to be over 65 years old, they had to have a blunt head trauma, and mean age for this group was 82 years old. They found that there was actually an acute intracranial hemorrhage at 7% for the no anticoagulation and 5% in the patients that were on anticoagulation. So a little bit of a difference there. They followed them out and they used things like calling them. So they were able to get about 55% of the people, they called them and to see if they had ended up developing a bleed or not. And then they also checked the Social Security death tracker to see if they had died. And they found, and did chart reviews as well, they found that there was only 7 people in the not anticoagulated group that ended up having a delayed bleed, and 6 people in the anticoagulated group that ended up having a bleed. That translated to 0.4% and 0.5% that ended up having a delayed intracranial hemorrhage. So I think this is really helpful in looking back at that original study and feeling a little bit better, knowing that the risk is about the same if they're on anticoagulation or no anticoagulation, sustained blunt head trauma, that they're going to have a delayed bleed after you've seen them. The biggest caveat to this is that the antiplatelet people were excluded from this, and a good majority of our patients are on antiplatelets, are on Plavix, right? So we need to keep that in mind, that was not included in this study, but I thought it was reassuring to know that intracranial hemorrhage bleed risk is a little bit lower than we thought, and then the delayed one is even lower than we thought.
Yeah. That's really important. Clopidogrel was excluded, but I think this highlights the other part of it for me, that my discharge instructions for the anticoagulated patients had always been, hey, if you're experiencing worse symptoms, worse headache, anything changes, gets worse, come back immediately because you could have a delayed bleed. But maybe we should be giving those same discharge instructions to the non-anticoagulated patients as well,
to everyone,
for the same risk of delayed bleed.
Mm-hmm. It was a select sample group, and they were observed specifically for that. So it was. I think it was more the study design, likely, that would cause the bigger difference.
But also potentially the patient population and the exclusion of antiplatelet and the poor follow-up. When I hear they were calling patients to see, did you have a delayed head bleed? I would imagine the ones with a delayed head bleed aren't really picking up their phones very often. I think there's partly design, but also partly there's the exclusions that were done in this study as well.
That reminds me of a callback I did. It was a 90-year-old couple, and I called back it was for the husband. The wife answered, and she would not give him the phone, but she kept yelling, like screaming into the phone, asking him the questions that I was asking. And the two of them were just screaming back to you, back and forth to each other. So maybe they didn't hear the phone ringing. I don't know.
I love it. All right. Abstract number 94 is an external validation of a tool to identify low-risk patients with isolated subdural hematoma and preserved consciousness. So we see many, many cases of subdural from mechanical falls, as we've been talking, or other mechanisms. And when the patient comes to the ED, we identify the subdural, and oftentimes their disposition is where? They oftentimes will go to the ICU because they have a head bleed. The authors here were looking to derive a decision tool to see, are there patients that might be low enough risk that they could go to a lower level of care? Perhaps they could go to the medical floor, the ward, rather than going up to the ICU. And so they did a chart review. Their methods were excellent. They came up with some criteria, and the criteria that seemed to correlate with having less bad outcomes were these. They weren't anticoagulated. They didn't have more than one subdural. Their hematomas were less than 5 millimeters. They didn't have midline shift, and they didn't have a GCS less than 14. So clearly you would have admitted these patients to the ICU. But the question that can't be answered by this paper is, if we were to admit all of these patients with all of these negative criteria to the ward, would they do okay? We don't know the answer to that. They to derive this tool retrospectively. There was no prospective derivation. There has been no external validation. This is, again, hypothesis generating, asking an interesting question of, hey, do we need to plug up all our ICU beds with every single subdural, or is there a subset that could do well if they didn't go to the ICU, which I think is a valid, very good question. But again, this is just starting that line of inquiry, has not given us, I would not be using this tool to convince our ICU docs that they're fine not taking this patient.
I would agree with that. The next one is Manitol or hypertonic saline better in severe TBI? Who uses Manitol? Who uses hypertonic saline? Who uses whatever the neurosurgeon tells them to use? Which could be either of those things. Yeah, okay, excellent. Same. So this study was a French study. It was done, it's a retrospective, and it was between 2011 and 2021, and it was a database that they were looking at, and it was 23 trauma centers across the board. They wanted to see which one was better, hypertonic saline or Manitol, for these severe TBIs. And when I say severe, these patients would die within 48 hours, some of them, so there was a good portion that did. They excluded those that died within the first hour, and they ended up including other folks that had GCSs less than or equal to 12 and had to have one dilated pupil, at least in the pre-hospital setting. So this is bad TBI, right? And the patient had to be over 16 years of age. And they were either given hypertonic saline or they were given Manitol, and it was 1,417 patients. They looked to see what ended up happening to those patients over time and whether there was a change in ICU mortality was what their primary outcome was. The things that they noticed was that folks were using hypertonic saline more at the kind of like the later parts of that data range, between 2011 and 2021, and I think that it was just a shift in using hypertonic saline over Manitol. They did notice that the majority of the Manitol, there was mostly Manitol, so 83% were given Manitol. And then when they looked down to see the mortality within 48 hours in the ICU, there was 45% mortality with hypertonic saline, but 54% with giving Manitol. Now, when you look at it, though, the patients that were given Manitol were just a bit sicker. And this overall population, they've already blown one pupil and have a severe traumatic brain injury. And the majority of the people in this population were given Manitol. So hard to say whether it was the Manitol that caused the worsening mortality or whether it was other conditions associated with the way that the patient presented that caused them to have that mortality anyway. So I think a lot have shifted more towards hypertonic saline and a little bit away from Manitol. That pendulum might swing again. Some of your sites might also be swinging back and forth, either to or from Manitol or to or from hypertonic saline. But it's really, there's so much more that I would want to know about the patients and about what happened and why those things were chosen than to say that it was the Manitol that killed them or caused the increased mortality.
Yeah, and we're reviewing all the papers from 2024, but there's big Cochrane reviews on this very topic that basically tell us that they're about equivalent. And the other big question for me is do they change patient-oriented outcomes in the first place? And they certainly, hypertonic saline, if you give it, they can start to bring down your ICP, but in terms of long-term patient outcomes, there's not awesome data around it, which to me just goes back to we need to treat these patients with severe head trauma, get them to CT as fast as possible, and then do all the other things, get their head of the bed 30 degrees, call neurosurgery if they need operative intervention. Don't slow any of those things down. If you have time to give one of these, it's probably fine to give.
So the ICU mortality was the only place they noticed a difference. Right. Everything else, early death under 48 hours, withdrawal of care, it was the same, 23 to 24%, and then ICU days and hospital days were about the same. So not really a dramatic difference in a very sick population.
Yeah, these are the suspected brain herniation. Mm-hmm. Abstract 96, we're going to talk more TXA. So tranexamic acid for traumatic injury in the emergency setting. This is a systematic review meta-analysis of TXA for everything. So they looked at TXA for many different things related to trauma, but basically all the RCTs, and they concluded that TXA mortality was lower with an odds ratio of 0.89 when you took all of the RCTs of TXA versus non-TXA in trauma settings. Now, but something to note in this study is that when you have a systematic review meta-analysis and there's one study that trumps all the other studies, that's sort of what happened here. You have the CRASH 2 trial that we've talked about ad nauseum, that if you give the TXA within 3 hours, you give it within the window, that there was signals of benefit for those that got TXA in severe trauma. But I don't know if we really dug into the methods of that paper, but that paper was, one of its strengths is it was multi-institutional across many, many countries. But one of its weaknesses is that it was multi-institutional and across many, many countries. And one of them, like there was hospitals in smaller countries that when our trauma surgeons had said, if you walk through there, they basically had no EMRs. It was a very different study environment. And so the data collection, how good was the data collection, how externally valid are some of those. But anyway, I think we're left with TXA is shown to be beneficial in CRASH 2, but CRASH 3, they changed the primary outcome. That's the one for head trauma. There's controversy whether or not that is beneficial. They basically did a subgroup analysis that ended up working. So people use it based on a subgroup analysis, and we've talked about it many times that if you change your primary outcome, you shouldn't be applying it. But in aggregate, TXA works for trauma based on the literature that we have, but largely because of that CRASH 2 trial.
Interestingly enough, the next study was done by a Chinese research group. It was a neuro group, also looking at TXA, also including CRASH2 and CRASH3 as the majority of their information. And they had 11 papers that they looked through, so 4 more than the one that Ramin just went over. Also published in 2024, also still looking to really prove that TXA will benefit. And what they came out with once they looked through all of the papers was that it doesn't help head injury patients, but it may, if you give it early enough, I think within 3 hours, to patients with mild to moderate TBIs, it may decrease the size of the hematoma, but the rest of everything else is about the same. What they did also note was that there weren't any events that increased as a result of getting the TXA. So PE, vaso-occlusive events, those were all the same. So they weren't increased by giving TXA, which is usually the reason why people give is, I don't know if I want to give it. For me, if someone's hemorrhaging, TXA is cheap, no real bad parts to giving it. I think I'm more apt to give it and see if it helps. Maybe there's a little bit of a benefit, but the research is just kind of still very much dominated by both CRASH2 and CRASH3 every time you try and get a subgroup or an analysis done or a randomized, not a review, a meta-analysis.
Yeah, and to me, TXA is sort of like not the main ingredient. You give do all the other things. We resuscitate, we give the blood, we make sure everything else is happening. The consultants, getting them prioritized for CT and the OR. And if you have time for the TXA, it's probably fine.
Yeah. Review.
All right, let's go.
What are
so
typical?
blunt head injury in elderly, even though patients had a 70% ground level fall mechanism, there were significant rates of head injury that required neurosurgery. Be careful in elderly patients with blunt trauma, even when they just fall.
What's the rate of delayed intracranial hemorrhage in anticoagulated head injury patients? And remember, this is not antiplatelets. It's actually quite low. It's less than 1%.
Abstract 94, isolated subdural hemorrhage. There was a clinical decision tool based on a chart review that was being derived, and it looks good on the chart review, but really needs to be prospectively validated to decide who can go to the ICU and who doesn't need to go to the ICU.
Is Manitol or hypertonic saline better in severe TBI? There's no definitive answer. Use what you have.
Abstract 96, TXA in trauma, systematic review meta-analysis, largely driven by the CRASH2 trial. There is some mortality benefit for severe traumas if given within 3 hours.
Does TXA benefit patients with serious head injury? It does not help serious head injury patients, though CRASH3 continues to confuse us.
That's right.